Hello everyone, this is Shadres from CDI 2025. I'm privileged to be with Dr. Yakov Elgudin to talk about his CV surgeon, talking about the new technology for CV for aortic dissection. Yakov, thanks for being with us. As a surgeon, being at CVI is always enlightening to see the collaboration between surgery and cardiology. So oftentimes, just before you, a resident or fellow presented a case of coronary dissection coming from aortic dissection. So usually from a surgeon perspective, how do you handle these cases?
It's very important. That's a very interesting and a very hot topic right now. I think we are at the stage right now when the endovascular options of managing aortic dissections, for example, extending or type A aortic dissection, going to the ascending aorta, now are not only we are merging with endovascular technique and open technique, but we're also looking to start moving towards using purely endovascular approach for the dissection management. It's not out there yet for the whole practice, sort of clinical practice, but it's moving towards that direction. And there's some pioneering work that's done by Dr. Qureshi in Florida that allows to approach the endovascular type A dissection with endovascular technique only. So far, we have been very aggressive in using combined surgical graft and endovascular graft, such as a Toraflex graft, which allows to not only fix the type A aortic dissection, but also set the stage for managing of the residual dissection in the distal arch and descending aorta and abdominal. So I think this is where we are at the moment, and I think this is where the future is going to take us.
In cases when there is aortic dissection and ascent type A and B together, do you work collaboratively with the vascular surgery to everybody will pair heads on section?
Well, it's a good question. We are very fortunate to have a real aortic center where we have the real-time discussions, real-time decision-making process when the patient with aortic dissection shows up.
Yeah.
We have the aortic call where we both cardiac and vascular surgeon, interventional cardiologists sometimes review the images, discuss the clinical sort of presentation and scenario and the plan of care. I think this is very important adjunct in the routine care where we make all the decisions together and then we go in and fix it. A lot of times, even if it's open repair with a hybrid frozen elephant trunk graft, it's done by a team of cardiac and vascular surgeons. Yeah. Not to say that the follow-up repair is also done by them.
Awesome. In terms of, is there any role for ECMO before or after? It's always you have that as backup for these cases, or it's a mandatory before you do these cases?
That's an interesting question. We tend to think that the type A dissection constitutes indications for emergent repair. The discussion whether a patient can handle an operation usually centers around the malperfusion syndrome, whether it's spontaneous malperfusion, cerebral, coronary, all of the above. I think this is where the complexity of this decision making lies. We do feel that most patients who are surgical candidates should go straight to type A repair. The scale of this repair, the magnitude of this repair, the approach need to be geared up to the patient, to the specific patient. But whether or not to manage patients who present with severe malperfusion, acidotic, and in extremis as a result of dissection, and manage those patients first with stabilization, with ECMO, and less invasive approaches. I think this is an important discussion we might come up with because we do have some patients who present in a condition that precludes any real operation.
Dr. Yakov, thanks again for enlightening us about emergency management of aortic dissection, type A and type B. Watch the videos and others on YouTube channel. This is Shadres coming to you from CBI in Austin in 2025. Thank you again.